you have the same system that you use every day, and you have three different cases. You have one guy with osteoarthritis, and you go for reverse. You have one guy with calf tear arthropathy, and you have a fracture case, and you go for reverse with the same system. Do you change something in your technique? Osteoarthritis, B2, calf tear arthropathy, and fracture case. For example, for me, fracture case, I don't like to lateralize a lot because I don't trust the healing of tuberosity, for example.
I think that is not the pathology, but what we have available for our implant. So if you have a fracture of the proximal humerus, a 4-part fracture in elderly people, it is just a reverse, and then you make as much as you can your reconstruction around the humeral component. But the glenoid was okay, so I don't have any special, assuming that it was okay, I don't have any special trick. Then the second case was?
One is calf tear arthropathy, and the other is osteoarthritis with a good calf.
Okay. Calf tear arthropathy, again, depends on the glenoid side. It depends on the glenoid side, again, but if it is nothing wrong, I just do a standard implant. And then if I have a relatively senior patient with a good calf, I have my question how good it is, depending of for how long the patient was not moving that arm, and I already explained my position in this case.
I mean, in my case, when I do it for fractures, I have to use the stemmed version of the implant. So I can't do, for acute fractures, I can't do a stemless, because you need the scaffold for the tuberosities. But the important bit is to repair the tuberosities back to the prosthesis, because I think Casanova was the first one to do a reverse for fractures many, many years ago. And they used to throw their tuberosities to the bin because they thought, oh, we don't need the tuberosities, it's a reverse. And the patients were not satisfied because they had no rotations. So it's a key, if you do it for fractures, to bring the tuberosities back and reattach them.
Okay. Which one? Which one? Which one?
No. Sorry, Felipe. So if you do a fracture, yes. I don't like lateralization. If you do an osteoarthritis, the calf is okay. You go very lateral and very distal. You go on the same case guide as you do in the calf tear arthropathy.
No. Regarding the fracture, I think that I am agree with Ofer that we have to repair the tuberosity to have a functional cuff. We have to restore the anatomy. Even you use hemi arthroplasty or reverse arthroplasty, it's the same goal. It's clear that. And if you want to reproduce normal lateral offset, you have to use the lateralization in the metal or with a bone graft. It's clear. Regarding the calf tear arthropathy, depends on the cuff. I think that if you have no cuff, you have to optimize the function of the deltoid. And we know that we have to optimize if you lateralize and distalize. So difficulty is how do you lateralize and distalize depends for me of the quality of the deltoid. If you have a good deltoid, you have to reproduce the anatomy because the deltoid is working well when there is an anatomy. When you have a thin deltoid, you have to distalize more. Because we proved with the delta a long time ago. I started in 1995 with Medinov to implant the delta. And it was magic. Because very old patient, very small, you put a delta with a superolateral approach. I didn't detach the subscapularis, and you restore active elevation. It's clear that distalization is very useful when you have no cuff and when you have only the deltoid. If you have a cuff, I think that you have to restore the anatomy. Even you use anatomic or reverse arthroplasty. And I did a CT scan after 9 months on functional cuff, reverse arthroplasty, because 75 years old, and I decided to put a reverse. And the cuff is working well. you have a very nice trophicity of the muscle. If you put at 80 years old a reverse, the reverse continue, the curve continue to work. It's clear that. It's the reason why this is a difficult choice now for all patients. Do you continue to do anatomic or do you do reverse? This is the question.
Can I ask a question for the faculty? What do you think when we talk about medialized, lateralized? Nobody mentioned talk about acromial fracture in relationship to the implant. So the main reason I'm asking this question is I changed for the past 3-4 years to a truly lateralized implant, even though the flexion or the function is better, but the rate of acromial fracture was higher, significantly higher. So, and I've done a study I'm going to tell you about in a second, but I want to hear from you, what do you think about, I know it's uncommon, but whenever it happens, we all hate it, because especially if the spine of the scapula, the patient loses function. So any comment from the group about it?
Well, I think it's a very good question, Bassem. It's a very good question, and I think like everything in life depends on the amount. If you lateralize 10 or 15, millimeters, you create more strain. If you lateralize about 3 or 4 millimeters, like I do or Philippe is doing, I don't know, Alex, you lateralize as well. 3 millimeters, between 3 and 5, it's quite good, and we don't see more than the others,
Yeah. I have a comment on this because it is a very hot topic in my mind, but the amount is correct. But the problem is that we always, so far, we look at the joint with one eye, on the glenoid side, the deltoid, and so on. In reality, going to some principle like the acromial index or the critical shoulder angle, we understand that the lever arm of the deltoid, that is the central core point of the function of a reverse prosthesis, it is variable in the anatomy from each of us. I mean, the lever arm cannot be lengthened or lateralized in a standard way if we want to obtain an optimal condition. I'm making studies on normal CT scan with the friends in the hospital of special surgery, but not yet getting some answers to this point. But what we should do, we do not lateralize. We should restore the best lever arm for the deltoid that is different from saying I'm lateralizing as much as I can, or I do not, or so. And it is not still a perfect algorithm, but we need to think about how much we have the acromial index, because my glenoid is here, your acromion is there, my acromion is here, the lever arm is different, and so on. So lateralizing is something that is not lateralizing, is not distalization, is simply restoring the best possible lever arm and wrapping of the deltoid. This is the principle, and then if you ask me, Alex, how much do you lateralize? My answer is I perfectly do not know, but probably too much is not healthy for the bone. This is the only point, but just to focus that I'm thinking about it, but I don't have an answer.
So because it is...
I don't know if you agree with this perspective.
I'm thinking the same with you, exactly, and I'll tell you what I have been doing, because it's driving me crazy. It's a very hard complication.
Yeah,
all of us...
devastating.
It is really very bad. You have someone happy, and it becomes phone diagnosis. They call you, I'm doing very well, I had to pop, and my shoulder dropped. You know it, done. And many times,
and no matter what you do, you plate them or you don't plate them, they still don't do
Alex,
well.
This is what's going to be for interest for you. So I have few of them came, some of them from me, myself, some from others. Some of them are medialized, some of them are lateralized. Lateralized are more. What I did after the repair mission, I took a strain gauge, intra-op, and I took the muscle stimulator, and I stimulate to the max. And I try to it's only rough, to get how much you have displacement of the acromion, and how much you have motion whenever you have lateralized or medialized. And what George Athol had determined in his lab was absolutely correct. Whenever you have more lateralization, you have much more force on the deltoid to elevate the shoulder. I'm a lateralized person. I'm using DGO. It's very lateralized. Even though you have a great rotation, you still have good flexion, but the contraction, the force on the deltoid across the acromion, only based on few of these. I don't have many. But this is in vivo, is much higher than medialized. Only one factor. I don't know, osteoporosis, the size of the acromion, the angle, this is only one factor.
I have a comment for that, and maybe a small trick. I used to lateralize I think, more than the other speakers, but I have 2 tips to see if I'm just correct and put the good anatomy back, or if I'm too lateralized on and I put too much strength on the deltoid. The first one is the subscap. If you open the subscap and at the end of the surgery, you have to pull too much on the subscap and it doesn't come in the lesser tuberosity easily, it seems that you are too lateralized. If you have some difficulties to reduce the prosthesis at the end, and you have a conjoint tendon which is very tense, it also seems that you have too much lateralization
This
or lowering.
very tricky, because you can do the same with the humerus.
Yeah, exactly. This is anecdotal, I think,
Yeah.
because it is not something that you can quantify.
I'm not sure you can quantify because you lateralize on the glenoid, but as you downward the humerus, the lower arm of the subscap is changed, so you don't really know what you are doing in 3D. In 3D, the only answer we can have for you is, I mean, really, there are many types of acromion fracture, from just the anterior part that is seen quite often seen. That's not a problem. We know that.
Only the spine.
But when it comes in the back to the spine, and most of them are iatrogenic with the upper screw, you have to be really in the. No, this is one factor, but most of them are iatrogenic with a posterior screw that goes to the spine, but not always. No, not always. Not always. But
I'm sorry, I'm not trying
we
to
must be.
This is really taking a lot of energy from me, because all of us in this room, we like to do reverse in certain patients and we love the result. But once you see spine of the fracture,
Yes, this is the end of the road.
for the patient and for you, when you see the patient doing this, barely, it's devastating. And this is why, even though the number is small, I really think with all our effort, we have to figure it out why and how can we prevent it. This is my question.
Philip, do you agree? I mean, you're shaking your head. What do you think about this?
Yes, I am agree, but there is not only one factor, and this is a difficulty to prevent this complication. And I'm very afraid as you, if you have this kind of complication, but I have not the solution to prevent that.
Philippe, believe it or not, I have a patient who had it on one side and they need the opposite side. They're scared. Do you know what I did? I plated before surgery. I did prophylaxis plating. I told him, you know what? I am happy, you're happy. I added one incision, but this way I don't have to worry about you.
Did it hold? Did it hold?
What?
Did it hold?
Yeah.
Because I plated them with sandwich, with bone graft, with everything.
I plated the normal shoulder, not the fracture one.
Okay.
I plated the other one so that it will not fracture. Yeah. So prophylactically.
Okay, Achilles.
This might be too aggressive.
Yes, please. Achilles Futsialis.
Thank you, Dr. Valenti, for the reference of our study. When we were performing the LSA and the DSA concept in France, we found that patients with the same LSA and the same DSA sometimes have different divergent results. And so what I found is the center of the rotation. Sometimes the bio-RSA is not so good because you're lateralized from the glenoid side, and it's not so good for the deltoid. So probably it's better to use the bio-RSA or the augments only to correct the inclination and the retroversion, and not to lateralize from the glenoid side, and it's better to do it with a non-lay system. And this gave the better results. I don't know what's your opinion on this.
If you talk about the lateralization, the main point, very important to understand that regarding the glenoid, it's not possible to modify a lot your lateralization, maximum 8 or 10 millimeters. But with the humerus, you can modify 15 millimeters if you want. You can put a curve, and you can put an onlay system with a lateral port. You can modify. And the most important is to understand that the cuff are inserted on the humerus. And the most important is to retention the cuff. And it's the reason why to lateralize what you want, it's better to have a modular system on the humeral part. Because on the glenoid, even you have a modular, you module of 5 millimeters maximum. On the humerus, you can do modularity of 15 millimeters. And I think that for the design of the prosthesis, it's more interesting to have a big modularity on the humerus part than on the glenoid part, because the glenoid is to prevent the notch only. But on the humerus is to restore range of motion and to prevent the notch, many factors to prevent complication. And I think that the design should be adapted to each patient, and it's more easier to adapt with the humerus lateralization for me. But the discussion is open.
As I said in my topics, I think that there is no ideal deal, and the fact of being able to lateralize in the glenoid and also in the humerus may be the good compromise. And you can lateralize make all your lateralization on the glenoid side or on the humeral side, or you can do both. I think maybe the good answer is both, but I don't know yet. I don't know what the other speakers think about it.
The point is exactly this. We do not know exactly how much for whom. This is what we need to understand.
I think that you have to analyze your patient, because if you do a retrospective study and you analyze the position on the CT scan of your prosthesis, and after you analyze the soft tissue, you can expect an idea for the future. Because the software, I agree with Kosturo, the software is not enough.
Philippe, but can I ask you, for lateralization of the humerus, other than this point, I'm talking about the rotator cuff. If you look at the normal shoulder, you have the center of rotation, you have the rotator cuff hugging the humeral head, and the moment arm is next to the tendon insertion. Now the center of rotation is on the sphere, and you're lateralizing, so the insertion of the rotator cuff, even though you're making it longer, but the line of impact is becoming more lateral. You have the center of rotation, and you're taking the insertion of the rotator cuff and putting it further and further lateral to the center of rotation. We're not taking this one into consideration, because the more you lateralize, you're increasing the length, but you're affecting the moment arm of the impact of the rotator cuff. Between the rotator cuff close to the sphere, which is supposed to be anatomic, and you lateralize now, you have length, but now that bone, the impact, which is the sphere where it is, the impact for the rotator cuff is really lateralized compared to the sphere. So this one has an effect as well, because the moment arm is not the same. So all of these factors becoming we add them together, you know?
Correct.
Yeah.
Any other question? Offer, what do you do do you ever felt that this is not stable enough?
No. You actually, what you do is you have the punch, the trial, and you impact the bone. And if it's not enough, you put some more bone and impact it until it's stable. Even the case that I showed, the extreme case, I didn't have any bone to take because there was nothing. It was eggshell. So I took bone graft substitute, 3 calcium phosphate granules, impacted it, and impacted it in. And once you put it in, it's very stable. And because of the forces, it's a reverse shoulder. You have actually pressure forces. It will get healed. And you see this LD patient, he got new bone, you know?
Thank you. End of the session. We'll be back for the